Hi, everyone, and welcome back to the podcast on another episode. I'm very excited to be here because this topic is truly near and dear. It covers what I do for a living as an obstetrician and gynecologist. It covers the medical field very directly. And it's sort of one of those touchy subjects. So I'm really happy that we get to have this conversation. Joined by a senior colleague of mine, somebody who's mentored me along the way. And again, it makes it for such an easy conversation because we are both in the same field, we are faced by the same challenges, and we do see and experience some of the issues our patients are faced with. So I think this is going to be quite an enlightening conversation. Increasingly, doctors in Kenya have been accused of not listening to our patients. We don't take the time to truly understand what your needs are. We've been accused of shaming patients when they come in for certain services. We've been accused of not participating in educating our patients in as much as we should be the primary source for information. And this cuts across all the different fields. It's not necessarily just gynecology. It cuts across all the different medical specialties. So I think it's time for us to address it from the medical point of view, in as much as we have some experiences shared by the audience. I'll be sharing and reading them out, and then we can comment. And I look forward to seeing what you have to say. If you feel so inclined, please message or comment and leave your own experience or your own comments around something that you may have gone through as well, so that we can continue to have the conversation and shed light to such a gray and dark area. I'm very, very happy today to be joined by Dr. Kigondu. I will allow you to introduce yourself so that we know who you are.
Thank you very much, Claire, and keep up the good work. My name is Dr. Simon Moshara Kigondu. I'm a consultant obstetrician gynecologist, and I've been in medical practice for 23 years.
And then everyone will say, you look too young for that number.
It's my father's genes. We are very happy that the genetics sort of help, but in 23 years, yeah. So, and an obstetrician gynecologist from the year 2007. So I've been round and about. I'm also the CEO and gynecologist at Excella Healthcare, which is a private partnership, gynecological and obstetric practice. We work together with Dr. Samuel Washira. And it's at KMA Center. And I also, I do a lot of health writing, so to speak. Yeah. So I run a blog, simon.moshara.kigondu.blogspot.com. And I also write a lot on social media.
Fantastic.
And yeah, all handles have my name.
Yeah.
Old school.
Old school, keep it simple.
Just use the same names. It's
and
easy
I'm
to
sure
find.
most people who will write in will say, yes, I know him from Facebook. I know him. He talks a lot about, and with a lot of passion, because that's one of the things most people have identified you for, is being very passionate about gynecology and the topics to do with reproduction and sexual health. So it's an honor to have you on this episode.
Thank you.
And like I said, it's one of those topics where most people would shy away. Maybe just in your years of experience, what has your experience been in as far as the accusations that we are facing?
Yeah, so the medical field is a very sensitive field. And what you need to understand is people remember how you make them feel. And that is if everyone could keep that at the back of their minds, then they would know how to approach even patients, so to speak. But before that, we also want to note that this field is clouded by very many health professionals, so to speak. So sometimes it may be important to differentiate between who the doctor is and who any other professional is. So sometimes when we receive these criticisms, we also want to ensure that you are actually talking about a doctor. And specifically, for instance, for gynecology, there are people who purport to practice gynecology and obstetrics. They are in the news for all the bad reasons. But when we go out there, you find they are neither doctors nor gynecologists, nor even clinical providers. So that is needs to be come out clearly to the public, because not everyone in a white coat is necessarily a doctor. But that does not mean that some of what the people are saying is not true. And indeed, soft skills are not inborn. And there may be some of us as gynecologists or medical doctors who patients may not feel, their encounter may not be very pleasant, so to speak. So with that, it is important for the practitioners to actually get feedback. Because if we start off, we may actually say maybe the doctors do not know that their engagement with the patient is actually not nice. So feedback is very important. When I was a medical officer, I used to be on night duty at a private facility in Nairobi. But I used to work as a medical officer in the rural area, but come and do night duty at a high-end private facility in Nairobi. So one day, we had a very good boss, so to speak, in terms of engagement. So one day from night duty, I went to night duty, and during the monthly doctors meeting, the boss, so to speak, he said, "Now, and you, Kigondu, there is a patient who said that when they were seeing you, you are looking like a packing boy."
Oh my goodness. A packing boy.
So for me, that was a light bulb moment. So what they meant is that there was this high-end Nairobi patient that we are seeing in a high-end institution, but you're working in the rural areas. Setup, you see, in the rural setup, they really don't mind how you look, but in the urban center, they mind. So it's very important to adjust, so to speak, to where you are. And more so also because it was at night, you are thinking that really anyone who comes at night can be casual. They are too sick. I changed my dressing and I started
you will have to immediately.
But it was because of the feedback. I did not know.
True.
Same thing with interaction with patients. So in the era of social media, as we came from an era where there was no social media, now the era of social media, it's good because the feedback is almost instantaneous nowadays, and also through other people.
True.
So the first thing I would say is that even to patients, give feedback. To if you feel that you are not treated well. And this really goes a long way into improving the doctor himself.
True.
So we agree and we apologize for everyone who ameongeleshwa vibaya. But for me, the first thing is feedback. And it is important that the patients actually give that kind of feedback. So the second thing we have noticed is that the character of the doctor matters. So doctors come from different backgrounds and different trainings and are of different characters. So there are some people with certain characteristics that may be construed as being rude and engagement. And that character is developed from many things. Now, specifically for medicine and for obstetrics and gynecology, it is the training. So the training is military.
True.
And once you come out there, you
went through an army-like situation.
Yes, it's actually military, as in it's this or this. You will fail, So then when you now go out to the real world, you forget to, that almost colonial mindset does not come out of you. And if that doesn't, then it's a problem.
True.
Then that can lead to your interaction like that. The third one is that majority of the doctors do their internship in public hospitals. Now, public hospitals are factories, so to speak. Like you have a line, you have 30 patients to see.
True.
There is no time for niceties.
Exactly.
You see. So the quality of nicety is not developed because your aim is to finish the queue.
Yeah.
So now when you move to private facilities, if you are not oriented or inducted in the same, you may continue thinking that you are moving a queue, and your interaction with patients may be, so to speak, public oriented, so to speak. So in my earlier years, when I used to work in both public and private facilities, and what I learned is that, in fact, I had one day said when I am the cabinet secretary of health, that doctors should work in both public and private. The advantage of a doctor working in both public and private is that in the private sector, you learn soft skills. You learn very advanced medicine, you'll get laparoscopic towers and things. Yeah. But in the public sector, you will learn the skills because the caseload is many.
High.
So the skill improves a lot and on this side. So it's really complementary, and maybe in future, we need to look for a way of actually having that doctor work in both. How they work that out would be good, but it is because it is beneficial for the doctor and the client. So when you're in private sector, you are forced to it's almost pretend that you're happy whether or not you're not, you cannot.
True.
So patient is king, so to speak. That doesn't mean that in public sector you shouldn't do that, but the pressures of work there may mean that probably you don't. So that's probably one of the ways in which these improvements can come. You see how to train these skills, but working in the private sector then now gives you the soft skills that you are complaining about, that a patient is not being looked at, is not being talked.
There's also the aspect of training, as you've mentioned. Ours is very militant, almost army-like. It's very focused on clinical skill. And again, because it's taught usually in a public facility, the pressures of numbers and time play a big role. Do you think there's room for us to actually integrate that training into the school system, into our training during medical training, med school and residency, so that we integrate professional skills training? I think that's the official term for it, so that we have the soft skills. You learn how to speak to patients, how to manage an angry patient, how to address issues as they are brought about, because you bring a point of feedback, but some of us don't know how to receive feedback. So do you think there's an important role we need to consider in restructuring our training?
So it's actually not restructuring, but now actually including this kind of training into the curriculum. But more important, because it's not that it's not there, but probably the way it is taught is theoretical. So, a small lecture on ethics, a small lecture on communication skills, but that's all. So what the training needs to do is to incorporate almost like a practical aspect of it. So just the way you do OSCEs for, a uterus is ruptured, then you need case scenarios about an angry patient and people actually listen to you. This is not does not occur in the, for instance, examinations for medical students. So we need to incorporate several things in the curriculum. The first one, of course, is the soft skills, the communication skills. How do you talk to clients? How do you relate with clients? And they should look for a way of course, in the clinics, you see, in the clinics, you see patients. So the consultant should demonstrate
demonstrate the skills yourself.
The skill, yes. So that in the clinic is not the place where you learn that rude language. Where mama, you get,
because that's
where
practice what you
practice what you see. The second one is important issues like confidentiality, those are taught in class, but
very
how do you,
theoretical,
in a
actually.
theoretical manner? So how do you teach that practically? Yeah. And so we ask about medical school, is confidentiality taught? You see? And that now dovetails to the other issue of insurance. So, for instance, you have been taught that you must remain confidential. But when you are given insurance forms and they want you to report a HIV test, so how do you report that? You see, so the conflict between administration and you as the medical professional know that you should not be writing things like that. So, but the insurance will not pay when you do not have. So these issues need to be thought about and discussed, and actually guidelines need to come out, I suppose, from the medical board, the council, on some of these issues that are almost taken for granted. Then in the training of medical students, how do you train confidentiality? Over and above the lecture, you see?
And especially in the scenario, maybe I paint a picture for the audience who've not had any medical training. The scenario tends to be that we stand around the bed and discuss the patient in front of them, in front of other patients. So just by the setup of that platform of education, you take away confidentiality. So how do we teach it if we are not enforcing it even in the practice of med school?
It's little things that may look small, but they're important to teach medical students, especially, so that they maintain confidentiality. So that once you leave the ward, for instance, and you're not doing consultation, you're not rumor mongering about
don't
people.
Discuss the patient.
Don't discuss. And this, by the way, also goes to the house. You are not supposed to go and discuss with your wife about a patient X you saw in the ward. That it might sound ridiculous, but you are not. Once you leave the hospital, you're
supposed to keep that information.
You're supposed to keep that information
pack
to
that side of your brain.
Pack that side. You become a husband or a wife. You get? Because those are the closest who you are likely to, sort of, you might know. It's very subtle, by the way, but you cannot be discussing, Claire today had gonorrhea.
Imagine
you cannot
how shocked I was.
Claire.
Imagine of all the people.
You know her.
You
are not supposed to do that. So outside, even your close relationships, doctors and other clinical people should be very careful.
So I'll read out one of the messages, an email I received from one of the audience, talking specifically about shaming by doctors. And then I want to hear your reaction and a bit of feedback, so we see what the gaps were, what the learning points are, because I'm sure there are younger medical practitioners, younger doctors in training who are listening to this. And again, teaching moments, we take full advantage of them. So I have permission to share this story anonymously. And so we'll start with, I was shamed for opting to get birth control. So I had done extensive research and I decided to consult a gynecologist on birth control. When I walked in, I was very happy that it was a female like myself, and I felt confident that I could have this discussion with her. Unfortunately, she shamed me for asking about birth control because of my age. She felt I was too young and I will read it as it has been said, focus on keeping my legs closed and focus in school. I was very disappointed, and I went to see my second option, someone who was recommended by an aunt. And this time, she was very understanding and responsive. She was able to take me through all my options and explain in great detail, much more than from my research. I felt such relief because it made me feel less demonized compared to the previous doctor. I was able to get onto a contraceptive and even further educate others based off of the information she had given me. And I was in campus at the time, so a lot of girls, we were talking among each other, and we were able to share that information. I asked her to give me a little point of what she thinks should have been done better. She said, I didn't understand why, based off of my age, the doctor had a personal opinion and expressed it as a professional one. I think that's a big area of concern. And if I had not found someone better or been treated better, I would have been traumatized and scarred for a long time. What are your thoughts?
Yeah, that is, and the mode of learning for medical school is similar to that, case studies. So with case studies, actually, probably points get out a bit better.
Mm-hmm.
Now, medicine is a cult.
You
and
just said that out loud.
has symbols, language, and what you're supposed to do.
Mm-hmm.
So medicine is a cult. So what they teach you is to come out of, to sort of make decisions based on the cult.
Mm-hmm.
As
Not
opposed to
your own personal
for wherever
opinion.
for wherever you come from.
Mm-hmm.
You are all lumped into this cult, and you're told this is how we do things, and for good reasons. The reason is that all of us come from a very different background.
Mm-hmm.
All of us come with different beliefs,
mm-hmm.
some opposing,
mm-hmm.
Beliefs, and all of us. And therefore, whereas you may put your personal touch
mm-hmm.
into the practice of medicine,
mm-hmm.
but there are sort of rules and regulations, so to speak, that guide your how you treat people. This particular case, it's simple. So if we approach her, she has come to the consultation room.
Mm-hmm.
So she has come to you because you are a doctor.
Mm-hmm.
So your role is to listen to her, then explain to her, in this particular case, all the form of family planning that she wanted. You explain to her, and then you give all the pros, cons, all the hows and hows, and let her make a decision. There is a concept in medicine called autonomy. Autonomy is where the client is the one who is in charge of all decisions made. So your role as the medical doctor or gynecologist is to give information and to provide the treatment, the most correct form of treatment or guidance as to when the decision is made. And as you rightly put it, one of the ways of improving doctor-patient relationships is to respect autonomy.
True.
You get what I mean?
True.
I'll give you the big worst-case scenarios where you have a Jehovah Witness. They don't want transfusion, but you as a doctor, you know that maybe you need
risk
transfusion.
To them,
you see?
They need a transfusion.
So you know that they might die, but they have even signed. If they find any blood in them, then it's on. See, those are tough ones, but these are an easy one. So autonomy is key. Secondly, so the doctor may have had perceived views on that kind of scenario. And we can, for instance, hypothesize. Maybe that particular doctor has a girl the same age in the same university.
True.
And in her mind, they are not doing a medical aspect. They are treating their daughter. So, and that's why they are behaving like that, or maybe that's how they were brought up, They were taught, military style. So what we are seeing here is that the doctor has put in their beliefs into or their practice or what they think should be done, as opposed to what the cult actually says that you should do. So I think if we go by the guidance of the medical profession, then it becomes very straightforward.
True.
You see?
True.
The doctor can now go like on Claire TV and give their views.
True.
You see, that is not a consultation point.
True.
That doesn't stop you from going out there and saying, hey, by the way, these girls from campus, we need them not to,
They need to focus on
They
studies.
need to focus on closing something. But
True. You can give a personal opinion where it's relevant.
Yeah, where relevant outside. Like here, you can go out and make noise, join bodies that make noise like that. Then you'll have others. You can have a debate. But when it comes to the professional field, stick to the cult.
True. I agree. You keep calling it a cult. Wait till you hear medicine trending as a cult.
It is a cult. It is a cult. So a cult, by definition, is a group that has specific language, specific practices, and specific symbols.
True. That's
so
that is actually
a lot
medicine.
of times the cults are portrayed negatively, but
medicine is a positive one. I like that. Yeah. What is your view on us doctors being patient advocates?
So this is actually what gives the doctor so-called credibility. A doctor is a citizen and a human being first. So he's a patient. He or she. They are a patient, you see. Then two, they interact with family members and all. So they're who as a patient. Then now when you're a doctor, you are now the village hero, so to speak, and you're the village doctor.
Yeah.
So everyone will be asking you medical questions about it. So you actually are a position in society where you actually receive a lot of views on then when you're treating patients, you are actually receiving the bad or good end of a health system.
Yeah.
You get, for instance, if there is no medication, you're the one who has prescribed and the patient dies, for instance, it is you who is blamed, not the lack of medicine.
We are the captain of the ship.
No, they know.
You have to sync with that
whatever goes wrong, it is the doctor. Whatever, it doesn't matter.
It doesn't matter. The machine wasn't working. There was no medicine. It doesn't matter.
Yeah. And therefore, you must be a patient advocate. And patient advocacy is at various levels. There is the highest level whereby you know all the problems of doctors and or the good things, and you advocate for it at a policy level.
True.
You get, for instance, you make contribution to policies or bills in parliament that touch on medicine. You make contributions on bills. For instance, national health insurance fund. You see, it is for doctors to advocate and say, oh, we need money in this so that we are able to ensure provide, that people do not enter into catastrophic expenditure when they get sick. You see, that's advocacy. So you move these bills. Then you also advocate at the local levels, where you say this facility needs these kinds of drugs, and when they are not available, you actually make that loud. There is also the advocacy of maandamano. You know, where we had a stint in 2017 where we brought out, by the way, we brought out a lot of things where initially they were claiming we wanted money. No, we didn't want money. We were advocating for the patient.
That was the propaganda. We were advocating for the patients.
But that now the weakest form of advocacy for doctors is this. What we are doing now is actually talking to doctors. Rarely go out to talk to people either on media or in the community. So we probably need a way of actually joining barazas of local communities, and you go out and speak your message. So I think the doctor should come out more and speak more. There are also ways by writing also, you write a lot of things and people understand. I do that quite a lot. And the feedback I get, I say, this is important because people did not know that, for instance.
True.
And the doctor is actually the advocate because he's at the highest level of technicality. Is the technically the highest person in the health system and should provide leadership, guidance over and above doing the work themselves. And this is an area that needs strengthening. And therefore, maybe in 2027, we'll get more doctors to parliament.
Yeah, true. I think we need to start to see, because we sit and complain when the wrong things are being done, or when we don't get the funding that we need to support our patients, but we don't actually step up to be part of the change, to be a change maker. And so it would also to serve to encourage lots of us now, get out there and talk to your communities. We get invited to church and we give health talks. You're invited to schools. You're invited to so many community setups and engagements. The chamas is one of those that I've been invited quite a few times, just to talk to the ladies about various aspects of their health. And I think that's such a great initiative.
Yep.
We just need more of us to do it, and to start to see it as part of your call of duty, not necessarily directly treating a medical condition.
Yes.
Yeah.
Yes.
Okay, I agree with that one solidly. One more. Another, again, I'll keep insisting, I have consent and we keep it anonymous. This was someone who was younger when she had this experience. So I was about 16 years old when I had my first diagnosis for a urinary tract infection. At the time, I didn't know much about my own body or understand what caused such infections. So when I was taken to see the doctor, I was feeling a lot of pain when I was passing urine. The doctor that I saw was an older gentleman, more like my grandfather's than my father's age. And immediately I explained my symptoms. He went into a monologue about bad practices, bad manners, and exposing myself unnecessarily and too early to boys. He shocked me because the things he accused me of doing, I didn't even know were done. I'm still traumatized even now, because when I have to see a doctor, I feel I have to compose myself. I wait till the very last moment. This was an unfortunate setting, especially since I've encountered better doctors and kinder people now that I'm older. And after having my first child, the gynecologist who I saw took very good care of me. My experience was traumatic, and I would hate for it to happen to anyone else, but I have had stories from friends that have followed a similar line.
Yeah. So again, we go back to the individual personality. So from that story, what we can get is that when a patient goes to see a doctor, the first thing they do is to what we call take history. Talk to you, we ask you, you started feeling well, and then we examine, and then after that send to the lab for some investigations, and then once you send to investigate, you come up with a impression, a diagnosis, then treat.
Yeah.
So from your story, again, I said case reports are a good way of learning. Is that the doctor did not take history, and if he did, he did not believe
the history that was
he
given.
just said this one is he did not believe the history that was given. But from the story, he did not even ask about any encounter, so to speak. So it is important for doctors to actually take history. It is also important for doctors to believe what they are being told. Although once in a while you may find that you need to really extract information, but it is for you to believe, and that's the only way you can come up with a sort of a rational decision. Then again, we also see in this particular encounter preformed beliefs on this particular practitioner. So I think what we are getting from all these complaints is a lot of preformed mindsets of the doctors is, in quotes, interfering with the accurate medical treatment. And as an extension, as I was saying now, that forms a side effect of giving people a mental disorder. Which you actually
you
start getting stressed, which you might not heal from, So that the problem with mental things is that they just stay there. They just keep recurring and can disturb you, from that. So we need to take good history, do examination, trust the person giving the history, and not bring our presumptions into the treatment desk. And when you do that, you actually save yourself a lot of issues, and the client makes. And it's important to. One of the reasons I like gynecology is that I like stories. People give me stories.
Yeah.
So when the ladies come there, they tell us about these men here who are disturbing them and all. This is very nice. When you listen to them, then you they give you a story. That's part of history taking, and it's also part of healing. Because a lot of people who come to see, for instance, gynecologists, just probably are looking for someone to talk
listen.
to.
That's true.
And
A large majority of the patients want to just have someone to listen to. Yeah.
So actually, that's how we practice. You listen for long, and you interject. And if we go back to the training that medical students and doctors, maybe gynecologists especially, would need to be trained on, include active listening. Active listening is a skill that needs to be trained literally. And so that if you don't listen, then these are some of the consequences that we get, especially when you see patients.
Yeah, true. One of the things that we face as a major challenge, I think, as medical providers who are looking after our patients in the 21st century, in 2023, is access to information online.
Okay.
And most patients will come having read extensively. Sometimes it's mostly misinformation or false information. It's opinions of non-medical people, because that's who is on explaining their own experiences and the what they went through for example, for treatment. So by the time this person comes to you, they have not only their own experience, they have opinions that they've read elsewhere. How would you advise doctors working now and seeing patients regularly now to navigate this space where everyone has access, everyone has a secondary medical degree?
Yeah, everyone is actually a doctor. I love that. I love a patient who has actually Googled, so to speak. I love that. So maybe I can take you back. As I told you, our years of practice might be many. Prior to access to internet, then the first step in consultation is to explain to the patient. You see? So, and before they catch, so to speak, that takes time. After the internet came, it is very nice. That they have saved us that time, that where you have to explain where this part is, you know. So that's a good thing. It's already helped so that you go straight into the business. The secondly, when they come to my office, and I did that as late as last week, is there's a nice song that goes, "Never Google your symptoms." Do you know that song?
I've not heard it. I will look for it.
You haven't got it's usually on my. I usually click there. So when they come, they say, "Oh no, Google." Oh, it is nice. It's a guy who says, "Oh, he was seeing his father. His father, he was almost dying, and the last advice he was giving him was, never Google your symptoms." So it was up, and so that is fine, but that's just how it's part of the icebreaker. But when they come like that, I usually tell them to start from the end. As in, you start from the end backwards, because if they start from the beginning where I don't know Google said, and that's how you sort of navigate. But reading is good. Patients should actually come to the doctor with a pen and paper. So as the doctor is writing, you're taking down notes. They should come with information. It's good you have read, so that you ask questions. This comes from an age where previously the doctor was God. You know, whatever they said, take this tablet, even if it's a stone, you swallowed it, you know.
And you believed you were cured.
But with time now, there is more access to information. And then also medicine is changing so fast that the patient may actually have new information, which you as a clinician may also benefit from. They say, "Oh, we are told about this." I say, that's good. I'll read about it.
I'll read that study.
But you also have an exchange. So it's good. Patients come with information. But patients should also learn to know that the doctor also has a point. And when they are given medicine and treated, they also follow these instructions after the discussion.
That's usually the biggest challenge
they have had, you know. Then there's also the other problem where they want, they have a specific medicine that they have read or have been told. Again, if the doctor declines, then just listen to that particular. But access to information has been one of the best things that have. It has even improved healthcare. You know, some of the things that you are thinking that were not there, for instance, are there. For a case in point is a condition called endometriosis. Endometriosis in our days was not there. Let's just put it there a long time ago. But with the time, as people start seeing more and more of these, you know, small pains in the abdomen, pelvis, and all, and endometriosis per se has come out to be a very big thing, you know. And nowadays, even if clients come with period pains, you see, endometriosis forms part of the differentials of some of the
whereas before
you know
it's not even factored.
You can't even have thought about it. That's as a result of information exchange.
True.
I think that's
true. I usually encourage my patients to come in with the questions written down. Like, what have you been reading? What questions do you have? Because I would rather be the source of accurate information than for them to go and lean elsewhere. And at the same time, I also encourage them that when they do see a doctor, it's a matter of also following through, because you will see a doctor, then you come see me for a second opinion, but even the medicine you are given, you're still holding the prescription because you didn't believe, or you're afraid, or you're skeptical. There's certain, and I think a lot of it goes to what we are talking about, just trying to reestablish trust, because that break in trust with your provider is what leads to these gaps that we are seeing. So it's just encouraging patients as they come in, read as much as you need to. In fact, if you want to bring me a folder, I get very excited. I'm like, let's read. What did you find out? And then as we discuss various options, I'm able to give you the accurate medical voice or opinion compared to, because again, the other typical thing they'll say is, but I read this and then I read this and they're the opposite.
Yeah.
So which one is true? Let your doctor be the guide.
Yeah.
Now, when it comes to patients themselves, advocating for themselves, what would you advise somebody who's going in to see their doctor, how best to prepare for their appointment in terms of advocating for themselves?
The patients themselves, when they come now, we urge them to be truthful. Sometimes you have dodgy patients that are giving you stories left, right, and because if you're not truthful, people don't get the correct diagnosis. You see, you might give, like, for instance, commonly in obstetrics and gynecology, pregnancy. Are you pregnant? No.
No.
You know?
When was your last period? Last week.
Last week. You get what I mean?
Yeah.
So that can be fatal. It's very dangerous too. So truthful so that the doctor is able to get to a correct diagnosis. Secondly, then we need to listen. Actually listen to what the clinician is saying. So patients need to that. Then you need to prepare. It's good, as I had said. They can read up and think, but don't come with a diagnosis. Just come and give your symptoms. Then we can compare notes after we've made a diagnosis.
Yeah.
Then more important again, because even at that relationship problem, maybe they should not be kutongoza daktari. So you have a male doctor and a very beautiful female client. Then I think the doctor-patient space should be left like that, because sometimes the young doctors and even the old ones can get confused by the patient who is coming to they like doctors, by the way. Doctors are very good people because they provide a listening ear, so to speak. So it's very easy to fall in love with your doctor. So we encourage patients not to fall in love with their doctors.
We discuss that in med school. It's part of the training, the transference.
Yes,
and it's actually a symptom of a condition. It's something that we make as a diagnosis, and patients need to actually be careful and understand that the feelings you're associating with your doctor of appreciation and that they listen to you, this is a medical professional. This is work. Keep it professional. True. And again, now that brings up the sensitive topic of the news feature we had recently, accusing gynecologists of crossing the line with their patients. For those who, again, the way articles are written, you can't tell if this is a medical doctor, you can't tell. So let's just assume that the story is as was given. But there were several reports by women of gynecologists crossing the line, some consciously while you're awake, others taking advantage and taking advantage of you with a sedative or a medication to keep you under control, so to speak. What are your thoughts when it comes to this area? Because there is a difference between abuse of your station and your profession versus transference by a patient.
Yeah. So a lot of recent news reports, and we keep asking the news people to retract some of these statements they make. When you say gynecologist, Mugo, he was called
He was Mugo.
Mugo. He's neither a doctor, nor he's not even a qualified health practitioner. That already sends the wrong message. But we understand it sells. You know, the gynecologist name sells that because typically, if you look at it from the state laws, that's a criminal offense, sexual assault and all. So a lot of times we would want to have more accurate reporting. But that said, there are those criminal elements that they're actually devious people in society, which we have rules and regulations and laws to guard against. So as we go back to what you are talking about, the patient should do their homework first before they go to specific places, so to speak treatment. But that said, as I was telling you earlier, individual behavior is very difficult to control. Know or defend. So if I am deviant, so to speak, it might be difficult to generalize and say these doctors, so to speak. And one of the problems we have is actually that generalization. So you say gynecologists are taking advantage of their clients. And when you say that, the whole profession retracts to defend itself. Yet there may be one or two truths.
You said we are a cult, and as a cult,
you
work as a unit.
You work as a unit. So a lot of the things are individual, and therefore human beings can do anything. So we wouldn't go out of them. But that is probably not the norm. But we should have ways of actually identifying this and reporting this. And whatever they are, so investigations, then that if someone does that, then you need to report them, report. But again, it's also difficult, especially in this. It's similar to cases of sexual assault. It's very difficult because you are putting yourself in a very dicey situation as a patient. So you need to we need to continue strengthen ways in which we can have help, ways in which someone can report, so to speak, and ways in which these corrective measures can be taken. But it is important for the patients to actually be in control, so to speak, with adequate information, with protection, and also be in an area where there is personally how we encourage our clients to come with their partners. You see, so the partner is a chaperone. Is the person who you are there when they are there when you are either examining them. So when people are with their partners, it's much easier. Then in the clinics, there are also other people who can provide us, in quotes, protection for the client. So those are some of the measures that can be put in place depending on your relationship with the clientele.
And then just to now close off our conversation, because I can see we can talk forever on this topic. Advice for doctors. How both our seniors, our juniors, our compatriots, what steps do we need to take to reestablish trust in our communities? Because it's not something we can hide our heads in the sand anymore. There are some big gaps and big areas and glaring areas that keep being brought up. How would you advise us to change this narrative?
So that's important. So doctors need to, one, establish a feedback mechanism. So the patient in your clinic needs to have a way they can comment on you, either anonymously or some form of feedback. And what can we do better? Then secondly, if something has gone wrong, you need to acknowledge it.
Yeah.
And with a duty of candor, you actually need to explain to the patient that, this went wrong.
Yeah.
And then you also need to demonstrate that something is being done to correct what went wrong and to ensure that this does not happen again.
True.
You see? Then the profession itself needs something called self-regulation, whereby you can call out your colleagues. As you said, it's almost a closed society.
Yeah.
Then we need to have probably the societies, the associations to call out colleagues in case things are detected. You are trying to check, you're like your brother's keeper, so to speak. And then we also need to give out correct information out there so that people don't call a non-doctor a gynecologist when they are caught doing something bad. That is sensationalism meant to sell news, so to speak. Then we also need enforcement of the rules and regulations that govern medical practice, If someone is going beyond their scope of practice, then action needs to be taken against them. If an institution is breaching codes of practice, then that needs to be identified and corrected. And more importantly, also, we need to continue having talks with our communities in shows like this one, in our writing, so that, and we also probably need to have medics demonstrate good things that are happening in that medical space, so that there is no monopoly of bad news. A lot of times medical workers do not report what they have done, and usually there is a lot of good things that they have done. And finally, we need to be patient advocates. So if you are a patient advocate, then that helps restore the society's confidence in the medics, and being at the highest level, being leaders, then you need to advocate for good things to go to the society. As we had said earlier, pushing for progressive laws and calling out, for instance, government on things that may affect on the delivery of obstetrics, gynecology, and sexual and reproductive health rights, so to speak. So if we speak out, society loves you.
Yeah, that's true. I like that. That's a good message to end on. So thank you very much for joining me, Dr. You have given us lots of insights, lots of gems for us to pick from. And I'd like to encourage especially the younger doctors. Mentorship is key. We have lots of senior doctors who have vast experience, especially so in these soft skills. And like Dr. has mentioned, exposure is also key. If you're able to place in a public facility and also get a bit of experience in private facilities, right now it would have to be proactive on your part, just because the system is not set up that way. But find the places where you can find mentorship in these kind of areas, so that you fine-tune your own skills, because at the end of the day, as you continue to see patients, it's you directly that it will influence, and it will make a significant change for the way your patients see you, and the way patients start to, and people start in our community start to see us as doctors and appreciate the work that we are trying to do for our communities. Thanks again for tuning in for this episode. I'm really looking forward to seeing your comments, or if you're feeling a bit shy, send a direct message. If you look at the description, you'll find all my information as well as Dr. so that you can reach out to us. If you would like to see him as well, I'll put all his information there. And we will probably follow up with a lot more conversations similar to this, where we are able to take on your questions and take on any of the comments, so that we clarify this issue a bit further. For those who are listening on audio, please take the time to rate this podcast. For those who are watching on YouTube, like, subscribe, comment, share. Thanks once again, and I look forward to seeing you next week.